So NOTCH1 is perhaps the most recurrently mutated gene in chronic lymphocytic leukemia. About 1 patient every 10 has got a disease that carries a NOTCH1 mutation. And this mutation, the effect of the mutation is the production of a shorter version of NOTCH1, which acts as a transcription factor, and the shorter version acts in a more prolonged way. So essentially it stays in the nucleus for longer time, and that implies that the signaling initiated by Notch lasts longer, and that the genes induced by NOTCH1 are transcribed in a more efficient way. And that is altering the signaling potential of the cell, making the cell more able to recirculate and to home into lymph nodes where all the action of the disease takes place. And also it makes them more responsive through the B-cell receptor signaling, which is in fact the driving force behind CLL. We have recently observed that there is a crosstalk between NOTCH1 and the B-cell receptor, in that NOTCH1 signaling promotes expression of genes that are important in the B-cell receptor signaling pathway, and the B-cell receptor can provide ligand-independent NOTCH1 activation. So in principle, there is a rationale for targeting both the B-cell receptor pathway, for example by using BTK inhibitors, which are already approved for clinical use for CLL patients, together with NOTCH1. Whether this is a feasible option for first line therapy or indolent CLL, I don't think so, because there is already a lot in the market and the BTK inhibitors work well by themselves. But for those patients that have an aggressive or therapy-resistant disease, or those patients who progress into Richter syndromes, this may be a viable option. We have done a small trial in animals where we have PDX models from Richter's patients, and we have shown that the combination of a BTK inhibitor together with a gamma secretase inhibitor that blocks Notch signaling pathway is more effective than each drug used alone and gives more prolonged survival.